Hi, my name is Kay. I am a community nurse educator for a local hospital. I'm here to discuss diabetic retinopathy and the risk factors that we as healthcare professionals can use in our everyday practice. The Journal of American Medical Association Ophthalmology published a study in 2021, prevalence of diabetic retinopathy in the U.S. 1 in 4 Americans 40 and over have diabetic retinopathy. We often see populations such as the Black population, 8.7% higher than Caucasians, the Hispanic population, 7.1%, American Indian, and then the Pacific Islanders. And as we tend to age, obviously the occurrence of diabetes does increase. Vision loss can be defined as partial or complete loss of vision that is permanent or cannot be corrected with glasses or contact. Any damage to the retina caused by diabetes is called diabetic retinopathy. The damage is permanent to the small vessels by tearage and leaking. When these tears form a scar, thickening of the retina occurs. Vision-threatening diabetic retinopathy is a more advanced stage of diabetic retinopathy, resulting from high blood sugar levels causing damage to the tiny vessels in the retina, leading to the fluid leakage and tissue damage. Retina loses the ability to react to light, producing a decrease in the visual field, leading to blindness. Other forms of vision loss, glaucoma, is elevated pressure within the eye that causes damage to the optic nerve. Typically, this occurs slowly and without pain, so a person will have a decrease in vision over time. Cataracts is a condition in which the lens of the eye becomes rigid and opaque and loses transparency, blocking and disturbing vision. The community health educator should educate individuals on potential complications seen from uncontrolled diabetes and to equip the patient with the tools that they need to manage their blood sugars. In the long run, this is going to prevent visual complications. When we look at risk factors for diabetes complications, not only is it uncontrolled blood sugar, but it's also uncontrolled hypertension or blood pressure. Also, hyperlipidemia, which would be high cholesterol levels. Those are some risk factors that we see in people who have diabetes that can lead to the vision loss, and also smoking damages the blood vessels to the retina, reducing the blood flow. So let's look at addressing these uncontrolled factors before the damage is done, and that is going to be our focus today. When looking at ways to help our patient, we're going to talk about tools and techniques the healthcare team can use to relay to the diabetic patient, further preventing vision loss. We're going to control our blood sugars and check our A1C and our blood pressure. Those three things are going to be very important. Individuals that do not check their blood pressure on a normal basis don't know what a normal range is. In addition to that, we'll often see people who are diabetics not checking their blood sugars. Therefore, they do not know if their medication regimen is working or if their blood sugars are within a normal range. So knowledge is going to be key. As healthcare professionals, we need to provide guidelines for patients by addressing how frequent they should monitor their blood sugars. In addition, what their range goals should be as far as A1C or their blood pressure. Also, providing equipment and education on equipment is going to be important. As a RN in the community, I often see new diabetics diagnosed with prediabetes or diabetes, and they are not given the education or the guidelines for what their target ranges should be. They are just given all this information at the very beginning of their diagnosis, and it can become overwhelming. So we need to do this over time and also provide additional resources. So for the aging population, all of this information can be very overwhelming. So we do know knowledge is key, but we also know the aging population in general has vision changes as they get older. It becomes very difficult to check their blood sugars. It becomes overwhelming with technology. So let's talk about some adaptive equipment that can be used for anyone. Talking glucometers are very beneficial for low or partial vision. Continuous glucose monitors are also becoming more popular. These provide the patient or client with hands-on, immediate information as far as their blood sugars go. It also allows them to monitor without pain using finger sticks and things like that. It also gives them the ability to monitor their diet and see what types of foods are making a difference in their blood sugars. The Dexcom 6 and 7 are voice-enabled continuous glucose monitors that are available with Apple Siri integration. It'll allow notifications through the app of low blood sugars and high blood sugars. So really educating a patient one-on-one is going to be important, or at least providing them the resources or a connection in the community for that. Studies indicate that continuous glucose monitors can help improve glucose control in older adults with a decrease in A1C, and it improves episodes of hypoglycemia for people 60 and older. If we decrease these numbers as far as their A1C and the blood sugars, we can prevent the complications of vision loss. Let's talk about some applications on the iPhone or other phones that can be used. Calorie King, it's a free app that can be used to track your food intake. MyFitnessPal, Food Ucate is the name of it. Apps, those are great for monitoring. Also, for someone who's visually impaired, an app called Glucon provides text and video for a glucon injection when you do have a low blood sugar. Ambassador Companion 24/7 is a voice activation for logging insulin doses and blood sugars and asking questions. And then Relax Lite, Lite, for stress management. That's going to be really important because we do find that patients who have a high stress level tend to have higher blood sugars and higher blood pressures. We want to keep those numbers lower. So social determinants should be considered when providing this education. So we will see that language can become a barrier. We did say that the Hispanic community is a large number of people with diabetes. So we want to make sure that the education material is in their language. There are also resources available in the community that will give you a one-on-one person to interpret for you. You can use Google Translate also. Cultural considerations, like we do ask that you consider someone's background and where they live. For example, I live in the South. We see sweet tea, foods with butter and fried foods very much part of our celebrations. Every birthday party has these, every gathering has them. Being a diabetic or pre-diabetic doesn't mean you can't have those. We just need to be educated on how to make adaptations to our diet. We see those more in the South, obviously. And with the Hispanic community, they may be high carbs as far as flour, tortillas, rice in the Asian population. So we would really need to take into consideration those things. We do want to provide our education in a way that is simple and can be used by everyone. I've had a client who had severe ADD, had difficulty remembering the concept, so it took a frequency, verbal, visual reminders, putting reminders in the phone, and hands-on classes. So just take into consideration how your client learns. In addition, a limited income can also affect how a diabetic or someone with hypertension sees results. Food availability, as far as buying fresh fruits and vegetables, do they live in a rural area? Those types of things, really seek out community resources that are available for you to provide to your clients, such as free transportation, bus coupons, programs that will come pick the patient up, local food banks. Is your client unhoused? Do they tend to consume foods that are higher in sodium because they're prepared, they don't have running water, no microwave. So really think about those when you're educating your client. And then last of all, just coverage as far as getting them into contact with the right provider. A provider that will spend time with them. As a provider, our community resources, we really want to dive deep into our community, meet our community where they're at, maybe reach out at local libraries, at schools, church organizations, and actually the workplace. We have found that that is a great place to go in and educate people on the risk factors to try to keep those down. When you're diving into your community, you want to be able to provide classes and education. An evidence-based program, if you provide that within your community or you're able to become certified to provide those, really does help your client. One particular program called DEEP, D-E-E-P, Diabetic Empowerment Education Program, is a CDC program that will allow you to provide education over 6 to 8 weeks, and you can become a trainer for that. You do have to be certified to teach the class, and it is provided in Spanish, the material is, and it covers topics such as understanding diabetes, its risk, the human body, physical activity, meal planning. So it is for diabetics, and it is empowering a diabetic to take control of their health care. In addition, there's the diabetes prevention classes, often called DPP. It is a CDC evidence-based year-long national diabetes program that offers lifestyle changes to reverse prediabetes and prevent type 2 diabetes. The classes can be free in your community, and it is a recognized program. You can go to the CDC website to find out how you can become a lifestyle coach to start a program in your area. Additionally, support groups are great for the emotional side and connection to others. So a diabetic support group is wonderful. The CDC offers tips on how to start one, and you can find that at New Beginnings. Last of all, encouraging recommended screenings for your client is going to be just one of the many ways that they are going to have control of their care. Clients often come and tell me, well, my doctor never told me that I needed to do this. So educating them up front on the types of exams they should have so that they can ask their provider for them, such as a comprehensive dilated eye exam should be given once a year to detect signs of common eye disease such as glaucoma, diabetic retinopathy, and age-related macular degeneration. Also, A1C should be monitored every 3 to 6 months. So a patient may have to be an advocate to get those test runs with their provider. So being able to educate a client on asking for those is going to be important. So today's discussion has brought light to diabetic retinopathy and visual loss, how it can be prevented. We identified the populations at greater risk for developing diabetes, which puts them at greater risk for complications, including vision loss. The most important contributing risk factor to address are lowering your blood pressure, controlling their blood sugars, lowering their cholesterol, and to stop smoking. An array of resources are available to the healthcare worker and patient, such as a talking glucometer for those that are visually impaired, a continuous glucose monitor, applications through the smartphones or iPhones, identifying and addressing social determinants of health, and encouraging involvement in education classes and support groups. Lastly, we recommend early detection or screening for vision changes, such as a comprehensive dilated eye exam. Thank you for joining me in the discussion today on diabetic retinopathy. I hope the tips that were provided allow you to make changes in your practice, addressing the risk factors that we see in the community.